Welcome to When Medicine Stops Saving Us, the Antimicrobial Resistance Crisis. I'm very happy and honored to welcome all of you into this space. My name's Abel Valenzuela, and I serve as Interim Dean of Social Sciences here at UCLA. Our motto in the division is engaging Los Angeles, changing the world. And it is this mission that we embrace and practice through our research, through our teaching, and through our service among multiple communities that we aim to serve. The work in the social sciences is dedicated to tackling serious issues impacting society, with an emphasis on promoting interdisciplinary collaboration across campus and within the community to affect positive and lasting change. We're very serious about this, and in many ways, the social sciences leads in very nuanced sorts of ways. We have multiple appointments across the college, but also in the professional schools. We oftentimes welcome unique programs like a program that will bring together anthropologists and sociologists with the medical profession. We'll be offering a PhD/MD. We do this because we know the importance of blending and integrating and problem solving through multiple lenses, multiple frameworks with multiple data. So tonight's event and panel discussion, in my mind, is a perfect example of the work that we strive to achieve in the division and model throughout campus, approaching the very real crisis of antimicrobial resistance through the lens of the social sciences. Alongside experts in the fields of biotechnology, infectious diseases, legislative and, of course, regulatory policy, pharmaceutical and medical device development, and filmmaking, we approach problems holistically. And in tonight's panel, we'll get a good feel, a good taste of that type of exchange. We believe that true advancements are made and big solutions are achieved by involving and working with experts and leaders across multiple disciplines who are all tackling the same issue from their unique areas of expertise. As the saying goes, if you want to go fast, go alone. If you want to go far, go together. I am particularly excited for tonight's discussion on the AMR crisis because of the impressive brain trust with us, not only in the panel, but also in the audience, both in the room here as well as those joining us actually remotely. We are going to be online. Please allow me to now acknowledge our host, Brad Burnham, who's the founder and the CEO of Turn Therapeutics. And of course, and very proud UCLA sociology alumnus, without whom this evening would not be possible. Many, many thanks, Brad. I also want to thank you for your tireless work and your dedication to bring the AMR crisis to the forefront of the public's attention and amassing such an impressive group of individuals to help us better understand the very real stakes, but more importantly, the possible solutions that can move us forward. So in addition to Brad, whose own remarkable story you will hear very, very soon, I would like to thank all of tonight's participants, Dr. Hannah Landecker, Dr. Tara Vijayan, Dr. Emily Wheeler, Dr. Jomana Musmar, for lending their time and their expertise. I would also like to thank tonight's sponsor, Turn Therapeutics, the Infectious Disease Society of America, and the Advocacy Association Bio. We are incredibly grateful for your support and partnership. Without further ado, let's start the evening with the screening of Holobiome. a new short documentary from the team behind the award-winning Netflix documentary Resistance, which, via a variety of creative elements, uses Brad's story as a thread to re-examine humanity's relationship with disease. Thank you.
Hi, my name is Jumana Musmar. I am the Executive Director of the Presidential Advisory Council on Combating Antibiotic-Resistant Bacteria at the U.S. Department of Health and Human Services. I'm delighted to be here, and after this this screening of this film, I'm sure you have a lot of questions, and we want to get to them. So the purpose of this session is for us to be able to better inform, give you some, more data about what's happening. And one thing that this documentary did is show that we are a society that is more reactive than proactive. And our goal today is really to give you the tools that you need to be more proactive and hopefully influence your communities and anyone else that you know to be aware of this storm that's here and getting bigger and bigger. But it isn't, we don't talk about it as much, but we want to make it as loud as possible. So I'd like to introduce our panel, and then we can pick up a few questions, and hopefully we can have our filmmaker join us also to help answer those. So I'm honored to be here with, of course, our man of the movie, Mr. Bradley Vernon, founder and CEO of Turn Therapeutics, and thankfully a survivor. Dr. Hannah Landecker, as you saw from the film as well, professor of sociology and the director of the Institute for Society and Genetics at UCLA. Dr. Tara Vijayan, medical director of antimicrobial stewardship and the associate director for the Scientific Foundations of Medicine for the UCLA School of Medicine. And lastly, Ms. Emily Wheeler, director of the infectious disease policy at BIO and director of Working to Fight AMR. Thank you all for joining us. So what did folks think about the film? Anybody have any questions at the top of their mind? Any comments about what they saw before we get into things? Okay. Yes.
Well, I just wanted to make a comment in general. It made a significant impression on me to be more proactive.
Well, thank you. But so what does proactive mean to you?
I was just saying to my partner that I wanted to make sure he was going to help me advocate for being a little bit more inquisitive on how many antibiotics I'm being put on. I'm just a lay person. I'm not in the medical field, but I'm curious now, okay, if I've been told to go 30 days on an antibiotic, should I really kind of do a pushback now?
Oh, it's interesting. Thank you so much for that comment. It's interesting you say that. And I think Dr. Landecker also mentioned that in the documentary. We don't know what we don't know, and we're finding out that we don't know a lot. And the only way that we can better do research is to ask the right questions and for you to be curious. So even when you speak to your GP, ask things. Don't just take things for granted, because there is an older, sort of more customary way of treating. And then there's the more progressive way right now because of all the information that's coming out. So asking the right questions, of course, is paramount because it's your own health. Right? Any other comments from anyone before we start off the panel? Okay, well, we'll riff things up.
Can I make a
Absolutely.
I would love to see the panel. It's kind of dark. Is it possible to bring the lights up?
That's a great question, and it's not for me. So does anybody here? Do anything? Take your phone out. Put a spotlight on us. All right, so Brad, did you want to react to the film since you were the star?
I mean, reliving it is an emotional experience every time. Actually, Dr. Bresnik is here,
Oh,
so
okay.
it's nice to have him here with me. If anything, it should help people realize, maybe put a face that this actually does happen.
Right.
It's that this isn't just a hypothetical. So I experienced it, and I think one of the things that we're lacking in AMR is something to visualize. Something that we recognize. We have that with cancer. Most people have seen somebody with cancer or a commercial for somebody who's going through chemotherapy. Most people have at least seen a documentary or maybe knew somebody who went through HIV/AIDS. There's a visual representation.
Right.
Even things like, I remember growing up, there was a Mothers Against Drunk Driving that came to mind the other day, and they brought a crashed car to school. So there's this visual representation, and with AMR, it's this big umbrella, heavy scientific term, and it's hard to associate that with things. And so if anything, I hope I can put a face to the fact that this is not just a hypothetical, like this is a now problem.
And on top of that, you were healthy. You didn't have any predisposing conditions, anything that would compromise your health.
No, not at
You
all.
just happened to catch this resistant bug that wouldn't leave because you were colonized,
It's
which,
the wrong place at the wrong time.
right, and that could happen to anyone. And I think that's a larger part of the message, is that you think that it's a small cut, or you think that it's a small infection, when in fact it actually can end up being something a lot worse. Yeah, well, thank you for sharing your story and for
Thank you.
being part of this documentary. All right, well, we're gonna get right into it. You heard a lot of terms that were that were mentioned in the documentary: One Health, interprofessional education, your microbiome, and all these things. So we're gonna get into those a little bit, but please, anything that comes to mind, ask us. That's what we're here for, and we want to be able to elucidate a lot of these concepts and truly show how wicked of a problem this is because of its interconnectedness with the environment, with the agriculture, and ultimately human health, and how it's all a cycle that is truly integrated. And we have to think of solutions that address this complexity as well, which elevates the problem altogether. So I wanted to kick things off with you again, Brad, and tell me, so we're aware of it, right? We're in the community, we go to these conferences, it's the same usual suspects. Globally, there are national action plans in certain countries that address this problem, okay? But is it safe to say that the public just isn't fully aware? And why aren't we as aware of AMR? Is the term AMR hard to grasp? Are people just not appreciating it as much? What do you think needs to be done so that we can raise awareness on a much louder scale?
It's gonna sound simplistic. I actually think AMR is a branding problem. It's an acronym. My mom was married to a cardiologist for 32 years, mother to a son who went through a resistant infection. I asked her a few months ago, what does AMR stand for? She didn't know. So if somebody with that kind of medical background, medical experience doesn't know what the letters even stand for, let alone the scientific underpinnings of the letter, that we're not getting the message out there properly. So yes, I think that we need to start communicating it better, creating connections with people like myself who've been through it. Yes, I think that scientists and researchers can speak to each other in a language almost entirely of acronyms. I mean, you can
Yeah.
literally put a sentence together, just acronyms, and all those people know what
I
you're
know,
talking about.
we speak Governese, so well, we
Yeah,
just speak
Governese.
in acronyms as well.
But that's alienating to the public. And you're right, going to those conferences, we call it an echo chamber. It's like being under a table during an earthquake and saying to the person next to you, the room is shaking. It's like, we already agree. So how do we get the people outside the door walking by who have no idea what this is and educate them in order to activate them? Because an activated public is what gets the governmental entities to start working on our behalf.
I mean, as you know, the government does have an effort, and we do have a national action plan for combating antibiotic resistance. However, it's not as robust as the other efforts that are out there, and it isn't as well funded. And it's something that we're constantly trying to make sure that it gets the attention that it needs with all these other competing priorities in life. But this is one of those things that it's loud in its own way, because the burden of this disease, when you're in the hospital in and out for 5 years, thankfully, you didn't die. However, if you did, you would have been a statistic that brings attention, but people underestimate the burden of disease, the morbidity factor, the quality of life, and the stress and anxiety that goes along with it. And somehow, some way, we need to be able to quantify that so that decision makers are able to see the value of what that is. But on the whole note of being proactive versus reactive, I want to ask you, Dr. Landecker, regarding history repeating itself. Okay, you've said you know everything about human behavior. We just got out of a pandemic. We freaked out for a few years, and now we're back to some bad habits. What is it that we're not learning, and what shift do we need to do so that we can actually take the lessons learned from history and truly be prepared, be it the next AMR pandemic, be it the next viral disease, which is more likely to possibly come, because we're not out of pandemic land. It's gonna happen again. It's not if, but when. What do we need to do to make change more permanent?
Well, I do think that to learn from history, you need to know what it is. And I really appreciated that this session opened with filmic storytelling, and it's really, it's a little intimidating to see your own face very large on a screen. I am not used to that in my particular profession, but it was an amazing job of putting together a whole lot of narratives that different individuals in with different expertises had, thinking about what will the present look like in the future. And I think a great job of storytelling. And we need really to be a little bit better about telling the history of antibiotics and antimicrobial resistance, because it is still really told as a heroic story, and then as a tragedy, right? That Fleming discovered penicillin, and the sort of heroic narrative of it, and then we're going to lose our heroes. And as I mentioned in the documentary, teaching about the history, you see that there are actually all of these incredible sub-stories back there in the history. So at the same time as we were thinking about antibiotics as a magic bullet and their wonderful properties, we were losing sight of bacteriophages, viruses that infect bacteria, as a potential thing to also harness and use in this way, as something that humans could perhaps use to live with bacteria. And so back there in the history, it's not just a thing that's over, it is still very much with us. So to learn from history, we might have to integrate it into these stories. I'm not sure we need a better word, but we definitely need better stories.
So it just makes me think about COVID-19. We do have crisis fatigue. I think that's very, very evident. And on top of that, what we're not seeing as much, but being in the industry, is that, we have a workforce shortage. Our public health infrastructure was definitely strained, and it is continuing to be strained. So in terms of preparedness, we're not prepared for anything else to come about. And unfortunately, I don't know if we're even doing a good job replenishing and being able to lift up our public health infrastructure and our workforce in particular to sustain what could possibly be coming our way. As we know, bugs know no borders, and they have no problem crossing over and infecting widely. But people don't know that AMR today, in terms of deaths, has superseded HIV and malaria together. Okay, so the numbers are staggering. They're not as prominent, I guess, here in the United States, but globally it is. So my question, Dr. Vijayan, is that considering these factors of crisis fatigue, workforce shortages, antibiotic access versus overuse, because that's also a conundrum that people can't really kind of grasp their mind around. We've been overtaking antibiotics because this fear of not getting too sick, but just taking something as a placebo effect, but it actually harming us down the line, versus places in the world that you can't even get to an antibiotic altogether. Could you talk about all of that?
Yeah, that's quite a bit. Thank you for inviting me, by the way. I just want to point out that last scene was very moving. The T with the keyboardless key, the computer was very, very touching. But as an aside, there's a lot here. I think it's important to recognize that AMR is just not hospital acquired, first of all, right? We're not just talking about hospital acquired infections. We're also talking about sexually transmitted infections.
Yes.
We're talking about the fact that people don't have access to healthcare to treat those sexually transmitted infections. We're talking about diarrheal illness. We're talking about global infections that are actually becoming more and more drug resistant, and that is terrifying. And so you know, all of these things, it's not just limited to one type of disease, it's all of the different bacteria. And so when we're thinking about access, we're thinking about access to antibiotics for sure globally, but we're also thinking about access to other things. We're thinking about access to vaccines that can prevent the viral infections that subsequently lead to bacterial infections, right? We're talking about access to clean water, where people that as the most common source of diarrheal infections. So all of these things are intertwined and interrelated and very much part of sort of the One Health paradigm that we're talking about. I think there's no question there's an antibiotic shortage. We only have about 50 drugs in the pipeline at the moment. Infinitely more cancer drugs, right? Infinitely more drugs for cardiovascular disease. When I actually think about what people die from who have cancer, it's actually most often it's infections. I treat a lot of patients with cancer. It's one of the most devastating things that I can see is these things that could be preventable that are not preventable. Right? And then when we're talking about, you know, I think I really appreciate the overuse comment that is, there's not a question that overuse is really what drives resistance. Longer durations drive resistance. I think that has been sort of a paradigm that was adopted since the days of Fleming. In fact, Fleming used in his Nobel speech, I don't know if you have heard about this, he used this anecdote of a patient who died from sepsis from Staphylococcus aureus because the patient did not get enough penicillin. And it turned out penicillin didn't work against Staph aureus since the time that it was discovered. And so his parting words were, if you're going to use penicillin, make sure you use enough. And that sort of, unfortunately, sort of carried on over the decades. But we've had a number of randomized controlled trials looking at duration specifically that have in fact shown that the longer you keep patients on antibiotics, the more likely you are going to select for resistance. So really focusing on duration, really focusing on who needs the antibiotics, and how we can get them these antibiotics is really important. And in much of the world, in some of our low and middle income countries, there aren't enough people to really steward these antibiotics. A lot of antibiotics are actually given in pharmacies indiscriminately, right? You can go to any local pharmacy and you can purchase an antibiotic. We don't have enough infectious disease doctors. We don't have enough antimicrobial stewards. We don't have enough antimicrobial pharmacists. These are all sort of really important figures in trying to make sure that antibiotics are actually used appropriately. And this is true in the US, where 80% of counties actually don't lack an infectious disease physician, to worldwide, where most countries actually don't have an infectious disease workforce. So those are some of the things that we can work on.
So if there are any pre-med students here, we need
Yes,
you to go
come into ID,
ID,
please.
okay? We just want to make sure. Dr. Resnick, yes.
So address patient expectations.
That's a great point, and I thank you for that. And that has to do with stewardship,
Yeah,
right?
it does. Yeah, I will tell you, and also actually when we're talking about workforce and how things are paid for, I'm sort of going to talk about both of those things simultaneously because it takes time to talk to patients, right? It takes time to also explain why something may not be warranted. And a lot of times we think of what is reimbursed in healthcare is actually interventions. But to actually have a discussion with a patient about not taking an antibiotic takes time. That is an intervention that is not reimbursed, and that's sort of the reality of our healthcare system at the moment. And so low-hanging fruit for most clinicians who are completely overwhelmed and seeing 30 patients a day is to prescribe the antibiotic, right? We just are not I think in the United States specifically, one of the biggest challenges in our healthcare system is the fact that we are not reimbursing time for having these really important discussions about risk versus benefit.
So how can we mitigate that? Because awareness would take away from the time that you need to take to describe to someone that you have a cold.
Yeah.
We're not going to prescribe a Z-Pak because you have a virus. There's got to be other things that we can do as a community so that we can address the issue and educate and spread awareness in a way, just like the concept of recycling. We always go back to that, right? Is it perhaps, teaching children at a younger age so that they influence their parents as well? Let's brainstorm some ideas.
I would love to hear from my sociology colleagues actually about
Okay,
this,
yes.
but I absolutely, I think we should be teaching at all levels of education about this, absolutely. I think, you know, our children are teaching us about climate change, our children are teaching us about, you know, access to clean water. I think really starting in would be incredible. But I think also the magic bullet narrative, I think we have to all sort of try to move away from that and really try to, you know, embrace just holistic care, right? How do we treat colds meaningfully? We treat it with rest, which we're not allowing people to do anymore,
Very
right? We're
true.
really not allowing people to rest. We're not emphasizing all the things, you know, fluids and you know, rest and sleep and all of those things. None of those things are emphasized anymore. So
Also, that it's okay to be sick.
it's okay to be sick
It's
and it's okay to
be
stay
sick for
home.
like 4 or 5 days, you're
Yeah.
fine, but
Yeah.
I appreciate your question because it definitely touches on the fact that, for example, outpatient settings have the highest number of prescriptions, and that's something that we're constantly trying to, you know, try to mitigate, because as you mentioned, our workforce is overworked. They don't have time, and these conversations take more time to sit there and answer the questions, and I'm sure every physician would love to do that. They just can't do it when they've got 20 people in the hallway screaming, right? So there's this balance, but just transitioning to you, Dr. Landecker. So if we were to do this like kindergarten campaign, something like that, so that if we teach the next generations at a much younger age, the distinction between those two things, what are we not doing to be able to nurture at least the future generations, so that we don't end up in the future with these guys looking back at us and saying, why didn't they do anything?
Well, I do remember when my daughter came home from preschool with a cold or something, and she got terribly, terribly upset. And she said, it's my fault because I didn't wash my hands well enough.
Mm.
So yes, I think absolutely. And I teach right now a class of UCLA undergraduates about the problem of antimicrobial resistance. Some of them are here in the audience, for which I am very grateful. Because I really think that learning about antimicrobial resistance is not something that should be taught to everyone to reorganize their behavior, but the more people who understand the complexity of the problem and their role as participants in it, the better. And our amazing undergraduates are going to go out into the world in all kinds of professions and ways and take that knowledge forward. I also think that we need to definitely think about human behavior, and we have folks in our sociology department who study at an amazingly detailed level the way that patients talk to doctors and the way that doctors talk to patients, and find things such as the order in which you ask questions or the order in which you make recommendations really makes a difference. So I think there are many, many tools within the behavioral sciences where we can work on these questions. But I also think that we need to take the larger sociological and historical perspective, which is, okay, human behavior and individual compliance is only one aspect of a problem which people in the One Health world and the planetary health world are now telling us, well, this is not just a problem of individual behavior, this is a problem of antimicrobial resistance genes in the environment.
Right.
And that there are many, many factors that are also social, but they are about the social regulation of antibiotics in agriculture. They are about human behavior, not in terms of compliance with antibiotic regimes, but perhaps overuse of disinfectants because of a terror of germiness.
Yes.
And the COVID pandemic has definitely done that. So yes, I absolutely think that we can use social sciences to think about how to make patient-doctor interactions better. And there's really a lot to do there. But I also think we need to be careful about saying the disease is the patient's fault. right? We can't blame this on patients doing the wrong thing or doctors doing the wrong thing. I think that it is a much bigger and much more complex problem than that. And it is a problem not just of individuals, but of the institutions that are responsible or not taking responsibility for how much of these biocidal substances are out there in the environment and
Right.
shaping the environment in which individuals are living.
I mean, everybody has Purell in their pocket or in their purse right now, right? That's one of the habits that we kind of learned from COVID. And I did want to, and I see a question in the back, and I'm going to get to you because I love that you have a question. The branding comment that Brad made. How are we branding this wrong? And what should we be doing? Because Emily works with companies galore that are saying, we want to work on this. It's just not sustainable. What are we doing in terms of branding that we need to sell in a better way? Is AMR the wrong term? Because if you said that your mom didn't even know it at that, you know, given your experience, is drug resistance, for example, a better term? I mean, anybody can jump in. I'd love to hear from everybody on the panel about what they think in terms of the branding question.
And, you know, I think the word superbug has sort of caught a little bit of, you know, of attention, but even then, it doesn't quite explain the breadth of what we're talking about, right? I mean, you know, like I said, there are so many different types, and it's not just, and I think a lot of times superbug is sort of associated with hospital-acquired infections, when in fact, it's much broader than that.
Right.
So I brought up the branding, so I'll take that question on. I got to teach in Dr. Landecker's class today, and I actually asked the class, what is a better term for this? You know, what are we doing wrong? And their response was, no more acronyms. You know, and
Makes sense.
I respect that. I mean, I do not come from a medical background. I'm self-taught. And I had to learn to speak acronym. It's a foreign language, you know, just to attend these conferences. And it took a while. And there's still acronyms that I need to learn. They said we want a word. But it's not just a word. I think they need some kind of a visual for the consequences of if we ignore them. You know, it's not just this could happen. I mean, this generation, even my parents' generation, did not live without antibiotics. You know, pre-Fleming, you get shot in the leg during a war room, there's a pretty high likelihood you're losing the leg. So nobody in this room, very few people, if any, that are watching this video have been around since before antibiotics were just there. So we don't have any idea what life is like without.
Right.
So it's how do we create that this is the consequence of not changing our behavior, you know, in people's minds, and what is the word to associate with that? So I think it's obviously a multi-tiered problem.
So we have to achieve that awareness in terms of putting the value of having an antibiotic that finally works, or at least keeping up with resistance. But to do that, we have to sustain a market that won't allow, unfortunately, with the way things are right now, having that, because you have this, like, you have the wicked problem of stewardship. Don't use it as much because we don't want the same problem happening again. But at the same time, we need to develop, and pharmaceutical companies make money from use, right? So how do we resolve this? Frame the picture for us.
Great. Thank you, Jomana. I think before diving into the unique market challenges of the antimicrobial sector, it's really important to dive a little bit deeper into something that some of the film experts spoke about, and as well as Dr. Vijay on here. The fact that there are not enough antimicrobial products right now to treat the infections that we have, let alone those infectious diseases and those superbugs that will come in the future. You mentioned that there are only a few dozen antibiotics that are currently in development today, compared to thousands and thousands for one type of cancer.
Right.
That is a problem because it takes a long time for a drug to make it through to approval. It takes on average about 10 years, and maybe 1 in 10 make it from starting research. And through all of that research and development, companies are needing to raise funds and to keep afloat and sustain those clinical trials and get to an FDA approval. There's a time during that research and development process called the Valley of Death, where companies often go under. And that's why we see that only 1 in 10 end up making it on average. Across medicine, when a drug is approved, that is a time for celebration because there's an FDA approval, that is a stamp that shows this drug is safe, it is effective, it is open for use in patients. And then a drug company is able to sell it on the marketplace. And the volume-based sales model that works for other areas of medicine fundamentally does not work and should not work for antimicrobials because we want these innovative products to come to the market and to be available for patients. However, we only want them to be used when they are necessary for the patient. And therefore, that makes a really good case for public health and limiting the use, ensuring appropriate use of these products, but it's a really bad business case. And so that's why we need to be approaching this in a fundamentally unique way to ensure that we have the products we need to treat these infections. Because of this really challenging marketplace for antimicrobials, we've seen the exodus of large pharmaceutical companies almost entirely over the past 10 years. And the innovators that are developing these products, 95% of those are small biotech firms, and over 50% of those are what we call pre-revenue. They have no products on the market, and they are moving forward a lead candidate that can attack some of these superbugs. And they are hoping and working to get that product to the market and available to patients. But then again, once it is approved, some folks say we want to leave it behind glass, break glass for the product to be used. I think it's not necessarily that severe. I think folks would likely agree, but we want to use that product judiciously and ensure that it is not being used unnecessarily. And that's why we need a different approach to really pay for these products to ensure there's some sort of a return so that companies are able to continue innovating. I think one last point that I'll note on the marketplace is that because of this fundamentally unique market that is uniquely flawed and broken, we've seen about 8 products, 8 new antibiotics developed by small companies that have been approved within the last 10 years. The companies behind every single one of those products have either gone bankrupt, have pivoted out of antimicrobial research and development, or have wound down activities or on a trajectory to do so. That is a problem, not only for the products that have made it to the marketplace and the products that will then no longer be available to patients, but also for any of the earlier stage research that company may be working on and for the researchers that are involved in that work. If a company winds down its operations in antimicrobial R&D, the wide majority of the folks that were working for that company will pivot into another therapeutic area and outside of antimicrobial R&D. This is all, these are all unique challenges to the antimicrobial ecosystem that really warrant a unique solution to stabilize the ecosystem and ensure that innovation can come forward to bring new options for patients.
And just to add to that, to give you a little bit more context, the government has a structure that subsidizes these startup companies, and millions are poured in to help incubate and nurture these companies to get to the point that they can finally be approved. And then, as you mentioned, they just can't survive the market, and you go through what's called the Valley of Death. And these companies end up selling their technology, usually it's oncology, and other areas that have the money to be able to sustain and continue. So the good news is, I know we're painting like a really dire, bleak picture. We're all gonna die. However, there's good news on the horizon. So there have been solutions. The UK is piloting a program for them to, sustain having new development, fully supported by the government. We have a similar something that's being introduced. Why don't you talk to us about Pasteur a little bit?
Absolutely. So there is some good news, right? I think there is growing recognition in the public, though there still needs to be more, as well as in Congress, in the administration, about the threat of antimicrobial resistance, really the impact of that on our nation and our world, and about the urgent need for action. As Jomana referenced, there is a lot of support currently in the US government to support early stage research and development through grants to support research and also some philanthropic contributions to support that work as well. What is fundamentally needed now is something on that post-approval side of the equation where the market for this ecosystem does not work. There's a proposal under consideration in Congress right now that is bipartisan, bicameral, called the PASTEUR Act, that would create a new and novel way to pay for the innovative antimicrobials that treat the most threatening infections. The PASTEUR Act would create a model that is not tied to volume, but instead is a subscription model. So under the PASTEUR model, the US government would enter into contracts with the developer of a new and innovative medicine where they can use as much or as little of that new medicine in federal healthcare settings that then provides a predictable return for the company to continue to move back into their research and development cycle, but one that is fundamentally rooted in appropriate antimicrobial use. So there is no incentive to use these products incorrectly, inappropriately, but there is still a way for innovators to recoup some of that costly R&D to get that product to the market, and then again, to go back and continue innovating. I know that the PASTEUR Act includes some elements of it to help encourage appropriate antimicrobial use and stewardship programs that are critical, as well as these elements for a new subscription style payment system.
And believe us when we tell you that this proposal has been looked at in every which direction possible for years through the federal government, through think tanks and other committees as well, to see what is the best way to approach this wicked problem that doesn't have a single solution, so we can at least try to have any new development that is sustainable and available within reason down the line. And so it hasn't been introduced yet, right? Because it's a new year.
It was introduced in the last Congress. We're still in the same session of Congress right now, so it's very much in play. And as Jomana referenced, there are a whole host of organizations representing not only industry, but infectious disease physicians, patient advocacy organizations, academic institutions, and others that have endorsed this legislation and think that it truly is the most important piece of the solution right now to ensure that the fragile antimicrobial ecosystem is stabilized to bring forward these innovations to patients.
So we have one of the many experts, his name is Dr. John Rex, and he is, one of the foremost AMR experts, and he refers to this sort of system as having a fire extinguisher. Everybody has a fire extinguisher, right? You're mandated to buy it. It's in your house. How many of you have used it? Okay, well, that's awful, but good thing you had it, right? So it's a similar sort of concept where you have that safety net, you have that available. Unfortunately, with the direction that we're going in, you may have to actually use this fire extinguisher, but we want to make sure that it's there for use when needed, so that the hospital systems, you get a crazy infection like what Brad had, and we already know, and the physicians that are in the hospital are already aware that there is this heavy duty last line of defense that we need to make sure that we give this particular patient, which is why we have it, which is the whole purpose of what PASTEUR wants to satisfy. So one of the things that we wanted to kind of infiltrate among all of you is you're aware of this legislation. Please learn a little bit more about it. You're going to see a video actually from the California representative in support of that as well. So please, if you're able to reach out to your congressman, full support is great, because this is one of the only avenues that we have right now to help support development and availability down the line as well. Question in the back. Did you still want to ask it? You're welcome to.
So I'm a student in Dr. Landecker's class, and my big question is, when we hear like issues like this that are so institutionalized and ingrained in our society, it can be really easy to develop that kind of hopelessness or idea of like patient participation, especially for not like medical professionals or students or something like that. Are there any action items or things that we as like common people or students can take part in right now to help
You stole my last question to the panel, but thank you for introducing it. So what are some takeaways that we can do as individuals, you know, to institute change? And they can be incredibly simple things. And I'll be the first to say, telling people the difference between a virus and a bacteria. As basic as that is, you would be surprised that the most brilliant people in your life don't know the difference. But Dr. Lander, go ahead.
A study for your tests. No, I think, you know, it's really interesting in the course of the time that I have taught this course on antimicrobial resistance, which is not just for science students, it's a general education course. It's one of the only ones on campus where you can choose social science general education credit or life science general education credit. But in the course of the time that I've been teaching it, I used to teach just one day on the microbiome, this sort of emerging sense that historically we've focused on the pathogens and killing the pathogens, and killing the pathogens is one of the things that drives resistance, right? And so it was very exciting when I started teaching the course. I was like, oh, well, here's a really different narrative. You know, this is about biodiversity in and on the human body. It's about resilience. It's about competing with pathogens to keep them out, those kinds of things. I was always really impressed by these learning materials and teaching materials with the microbiome. They're so optimistic. They're so, it's like the microbiome is all rainbows and unicorns. And then antimicrobial resistance is off here, you know, with the thunderclouds and the lightning, and it's like utopia and dystopia, and it's they don't merge as much as they could or they should. So one thing that one can do is learn a lot. And if you think one way about bacteria, and you know you just have this given narrative in your head. It is so easy to open, you don't even have to open science textbooks. There's really wonderful science journalism out there. There's all kinds of ways to learn much more about the bacterial world, about humans as occupying a microbial world. And that when you learn about that, you're not just learning about AMR, you're opening a sense of how you as a human organism should live in relation to other organisms. So maybe it's just because I'm a college professor, but I do think that learning is the first step to being a citizen of the world that can operate in more thoughtful and critical ways out there, given the problems that are ahead of us.
And asking the right questions. Making sure you just ask. If you're not aware, it's okay to ask. So that there's simple items that I just thought of as you're discussing this. For example, don't throw away any unused antibiotics. Take them back to your CVS. Have them dispose of it the right way. This is what One Health is, because anytime you throw it in the landfill, it ends up in the environment, and that's something that ends up in our water systems as well. And the cycle continues. So this is where you have to think ahead about these things, but I know you've been very patient. Please ask your question.
I'm just speaking as a cultural anthropologist, and I'm thinking that the way that this is set up, and I can see where each point of view is. I'm thinking that if we look at health maintenance or improving the resistance, and you look at it culturally, cross-culturally, look at it historically, traditional versus non-traditional. But I think in general, in the United States, when you go and see a doctor, like the fourth speaker, third speaker, they only have 5 minutes or so, 10 minutes. Right. And similarly, in education, we don't teach basic human biology or just general bacteria stuff until middle school. So what I'm saying is that people can be a lot smarter. Kids are a lot smarter. We can teach them the difference between virus and bacteria, how they replicate, why antibiotics doesn't work for viruses. Those are things that you could really teach, but we're never ever going to get it.
system. So my suggestion is, for everybody interested, teaching is not just to the children, but also to the parents.
Right.
Because when you get infections, you
Yes.
go to the doctor, it's going to be amoxicillin or some amoxicillin, and then they keep getting repeated. And so that's a good opportunity to teach about general resistance to this kind of
No,
stuff.
thank you for that comment. It starts at home and you're absolutely correct because this is one of those areas that parents can teach their children. Yes,
This
go
is
ahead.
one of the things
Yes.
that so many students who might become doctors. I find it extremely weird that doctors, medical students do not get far more education and nutrition. Because there's
It's a
so
great
much,
point.
so much you can do to increase your biome, more important, the health microbiome.
Yeah.
I mean, taking kombucha, all kinds of stuff that really helps build up your microbiome. And these are simple things. So I'm thinking that maybe the place for this education is in a nonprofit organization, an internet-based type of educational information.
So thank you for mentioning that because that actually segues into what Dean had mentioned in terms of interprofessional education. So a lot of the programs now are actually doing rotations, not many, not as it should. Medical students that go into the veterinary schools, learn about agriculture and how the veterinary world functions. And the veterinarians are also going into the medical schools as well. So this is, again, One Health in action showing how those two worlds do cross and they're fully integrated, but we need more of that. So thank you for that comment. Yes.
So, first, never go to Washington DC if you don't like acronyms. Second, Congress is divided into 2 sessions, so it's the same Congress, but second session.
Correct.
And then, my question was, how do you create urgency without trying to scare people?
That's a great one. How do you create urgency? And I think, is Michael Graziano here? I wanna pick your brain a little bit. I love how you did the angle where the future was looking back and just shaking their head, be like, these idiots. They didn't do anything. Why didn't they do anything when the warning was there after all these millions of people died? How did you think of that concept and why did you do it because I thought that was brilliant, that you did this look back at us being reactive rather than proactive, and this is where they are.
Yeah, thanks for the question. Well, I'm a fan of existentialists and so Camus in particular, because of his humanism and the way that they answered these big intractable questions confronting them at the time in the wake of the Holocaust and World War II. They were kind of asking themselves, how can we live in light of this horror, in light of this terror? And at least for Camus, the answer was, we have to take responsibility and we have choices that we can make. I know it's more complicated than that, but I do think one of the things, so I think that's really relevant today for young people, especially confronting all of these calamities that seem to be burgeoning, that are climate change and all of the things that's driving, and something like antimicrobial resistance, which people say you should call drug-resistant infections, that people understand that term better, and I probably agree. But I think that like a way to engender concern without causing panic is to empower people. And it comes through education, but it also is like speaking honestly and directly to people about, the issues that they're confronting and helping them understand that they have a voice in this. Like if you go to one thing that I learned from my previous film in the screenings is this, and this is a very practical one. If you go to the doctor and they want to give you an antibiotic, ask them why they think this is a bacterial infection. Right. That's the question. Or why do you think I need this, at least? And statistically, the data shows, and statistically significant way that if you ask that question, prescriptions go down. They go way down. So that's just one thing.
Thank you for that. Go ahead.
So even though a lot of the starts with getting the public data, it can be hard for that to be possible when there seems to be no straight answer that exists, and or it can take more work for the average person than they're used to. So my question was, to what extent can we sacrifice nuance and like an all-encapsulating understanding of the complicated issue for just getting the information out there in a digestible and useful?
Anyone want to take?
That's an excellent question. I think that my immediate response to that is that different messages and different communication methods and different ways of educating folks work different for different people. I think we learned throughout COVID-19 that a trusted messenger and working locally with people in your community and ensuring that be that in a faith-based network, be that in other community settings, works to ensure that messages get conveyed in a way that the people that are receiving them can understand. And that means the message might be different on what antimicrobial resistance is, what drug-resistant infections are, and how you can treat them, how you can prevent them, how you can avoid them, and the changes that we need to make from a policy side of view for a undergraduate audience, for an elementary school audience, for folks that are in DC and are living and breathing policy every day, and for folks that are not. I think that we benefit from having different messages, different ways to communicate that. Some people learn from film, some people learn from charts and infographics on a page. And I think that we need the whole gamut in order to raise the awareness to the degree that it needs to be, and to ensure that folks with all different types of learning styles can understand the gravity of the situation and the action that must be taken to address it.
And thank you for mentioning community, because the sense of community is very strong and undervalued. You influence probably 10, 15 people in your life on a daily, if not weekly basis. So your influence will resonate if you're able to have even a simple conversation like, you know what, don't use the Purell. Wash your hands. It's okay. So even the simplest of messaging that you could actually communicate to a friend may elicit additional questions, and you've already done something to help improve that and provide the message that's as simple as that. So I manage a presidential advisory council. All we do is AMR all day, every day. And we do it from a One Health approach: human health, animal health subject matter experts, and environmental health subject matter experts. And we approach this topic publicly. So we host public meetings and we provide that platform for the interface between anyone, industry, policymakers, all of you in the federal government as well, so that we take your feedback and we take your advice into consideration as we provide recommendations to the Secretary of Health and Human Services. And we discuss anything and everything under the sun. So what we realized early on are two big, best practices. One is, don't isolate the agricultural community and don't underestimate where One Health is in your life. Who has a dog? Everybody has a pet. The way you treat your animal, the same rules apply when it comes to antibiotic stewardship as it does with your pet. If you go to the doctor and they give your pet a prescription, ask why. Because we're finding that the prescription rates also in the companion animal community are very high. And everyone, especially during COVID, there was this huge panic that went through, and veterinarians till this day are completely overwhelmed. They're part of that workforce that's also overworked and burnt out as well. So there's a lot of influence that you can do. And also, as a person that understands at least the foundation of the issue, the way that you digest it is the way that you're able to transmit the message to others, because you're all speaking the same language together in a way to, better understand each other. Yeah, go ahead.
So I just had a thought about how this might be more palatable to the general public. Right now, we're in a very academic environment. We're listening to experts, scientists, educators, and I certainly value that. But I also know that a decent amount of people in the world would appreciate a good story, right? In the form of like a Disney Plus platform, or Apple distribution, their distribution, or a TikTok. where the story is designed kind of like, remember Rick Moranis and Honey, I Shrunk the Kids, some kind of very beautiful story talking about like a family and their whole kind of journey through something tragic, but charming nonetheless. And there's a happy ending because there's some practices that are being now propagated through hand washing and not just about, hey, we're going to take care of ourselves, but when we do these practices, we're looking after our community. So it's not just a selfish choice, but like during COVID, there was a beautiful kind of ad that said, I don't put this mask on for myself.
Right.
I do it for my community, right?
Right.
So if we can shift it from how to take care of ourselves individually and be more about the community, I think that is a beautiful message. We could start to create some programming either through film, Disney kind of platform, or in the kindergartens, in the preschools, and propagate through the homes that way.
No, I
Just
completely agree. And I was telling Brad, does anybody here know Madonna? Because we need Madonna on board to try to hopefully push this message. So we need a celebrity at some point that's able to share their message, but I digress from that.
So I have a second part that.
Yeah.
And
Go
that
ahead.
is, so that's the side of telling the story.
Yes.
How do we take those pioneers who are bold enough to do the science and take on the financial struggle of getting it through and the legacy system of approvals of 10 years and trying to get that emergency use authorization? How do we time collapse and financially collapse the whole process so that it's not just, you're winning, you get somehow chosen in the lottery to be expedited through? Like why does that exist? I know it's for safety reasons to go through all the different steps, but what is unnecessary? Why are we still facing that incredible queue that they have to go through? Where is the financial burden truly coming from for those companies?
So you've got two different points. I want to make sure that I understand. One is how to get the message out there more creatively so that it resonates with more audiences overall. So just to let you know, there's actually a play about resistant mold that made it to the Kennedy Center on the East Coast. I don't know if it made it to here. It's out of the UK. What was it called? The mold that broke the world or something? Yeah, so there is a play. If it's as exciting as Mulan, I cannot guarantee, but there was a play, and I think it is coming back to the US as well, and it does talk about resistance, and it's a musical. There also is, I think, a movie in the works, the Phage folks, the Solomons. I think there's a crazy story out of San Francisco about a couple that ended up contracting, at least the husband that contracted a highly resistant bug during his tour in Luxor in Egypt and actually felt very ill. And on his deathbed, his wife ended up saving him because she's a microbiologist. And she kept researching we didn't have anything in the US, and she ended up going to Georgia. And phage technology saved him. So that's what the story's about. And I think there may be a movie coming out about that. But phage technology is one of those innovations that we're hoping that we're constantly learning about. NIH is doing tons of studies on it. That may be another source other than antibiotics, because we need alternatives, not just antibiotics, to be able to address the plethora of pathogens that could hopefully be there. And in terms of the second part, the emergency use authorizations are there in the government to expedite a process, okay? So whenever an emergency is declared, that's when you're able to move a drug and kind of bypass a lot of the paperwork, which is what happened with the diagnostics that we ended up having during COVID-19, which is why we had a lot of diagnostics, and everybody here knows what a diagnostic is. The good news is that the EUA process, hopefully, maybe, with the use of AI at some point and being able to digest data at a faster speed, support that. What that looks like, I can't tell you. But the process is there to help, and I think, and correct me if I'm wrong, your question is, why does it still take too long?
Yes. Why is it so
Government.
expensive? It takes millions of dollars, I've heard, to go through every one of these stages. Where is that money going to? I know there's studies and things, but like, who's getting rich off that process?
So for the EUA, nobody's getting rich, trust me.
Okay.
But go ahead. Dr.
Well, I was just going to add, you do have to have participants in studies. And I think that that's a big barrier, actually. You have to have healthy participants. It's really hard to get healthy participants. And, and I'm not a researcher, I'm a clinician, as well as somebody who oversees a couple of different programs. But, it really, it does, the R&D process does take time for recruitment. You also have to do things fairly with appropriate consent. You have to make sure that everything is equitable. I mean, all of those things do take, they do take time, and they should take some time,
Right.
maybe not 12 years. But you want to make sure things are done correctly.
In addition to the range, so you have pediatrics as well. And then you have senior citizens that are also in a different category, and then you have healthy adults. So getting that patient pool is always very difficult when it comes to clinical studies. And actually part of the reason why we don't have the right pediatric doses, because we just extrapolate from the adult doses, because we don't, I mean, who's gonna put their kid on a clinical study, realistically? So that happens. We have a much smaller data set and pool for that, but it's the difficulty of doing things ethically. But we have to do things. Any other questions from the audience? Yes.
Quick one here. I just want to say how much I appreciate this conversation. I mean, we've talked a lot about the sort of darker patient side. We talked about the narrative, the media piece, but there's an advocacy piece that I think is really important here too. And so many of our models of patient advocacy are around expanding access to care. We think about families of rare medical conditions, where they have patients in their family who are trying to get access to a particular drug. We think about people who have particular experiences trying to get access to drugs, and so much about that is expanding access.
Right.
Whereas what we're talking about here is responsible access, I think, which is a different kind of thing. And I think we need better narratives and ways to get survivor experiences out of it too. So I wonder if anyone has examples or things that we could think about how to do effective collective advocacy rather than just the educational side of the documentation.
So the advocacy side is growing. Is it where it should be? Probably not. There are a lot of grassroots organizations. So for example, our council that we have, which is all subject matter experts, we have a patient advocacy. It always needs to be filled, and we always need to have that voting member that's there to voice for the patient. But we also started a trend at every public meeting of starting with a patient story. We get so heavy into the science and into the policy that we just needed to see why we're doing this and who are we doing this for, which is actually how I met Brad, as he came to our council and we shared his story and how he ended up, finding Turn Therapeutics. So this platform also has a particular audience. It's not the general public, but I know that there's a lot of working communities. You had mentioned, STIs, sexually transmitted infections. We don't discuss resistance as much, but gonorrhea is on the rise. Congenital syphilis and syphilis is on the rise, borderline like public health emergency level. So while we're mentioning the disease itself, the resistance component is very, very strong, and which is one of the reasons why it's ramping up so quickly. So the communities involved in those particular cohorts and folks that need the advice and actually go to somebody trusted to get the right advice exist. And I'm not in this world, but my understanding is that finding out about those communities is also a gap that we need to bridge, because the resources are there. We just need to make the connection.
I'd actually like to make a comment. There's the anthropologist in the back. I'm sorry, I didn't catch your name. Probably Dr. something. What was that? Okay. Hey, I was responding to something you said earlier about teaching kids younger. I'd like to. So about a month ago, during the microbial section in a 5th grade class, I went in because I wanted to prove that you could actually teach kids this young about antimicrobial resistance, antibiotic resistance, and it was not hard. If you break it down to understandable, digestible information, that this is a cold, this is an infection, this is why you should take all your antibiotics. I mean, the concept of evolution is the same. I would say that bacteria are a little bit better at it, a lot faster at it, but growing resistant to current threats is also what humans do. Bacteria do it about 500,000 times faster for human generation. So I think that one of the reasons why books like Harry Potter did so well is because they didn't speak down to kids. So I actually think that we actually have to start valuing what they can learn and at what age they can learn it more. And that experience in that classroom where we had kids at the end who were teaching each other I mean, they knew the name Alexander Fleming by the end. They knew why you should finish your bottle of antibiotics. They knew you shouldn't take an antibiotic if you have a cold. These are fifth graders. So we don't need to wait until people are much older and usually entrenched in their ways. Let's just say it how it is. And information's a bit like an infection, it spreads. And I'm often taught my children as much as we do teach children. So I think that very much, I agree with your point that we need to start respecting how much kids can learn and when. Actually, was even thinking about doing a canned curriculum, potentially a children's book. There are probably ways to get information out there, earlier. The earlier, the better. So thank you for that point. It meant a lot.
Thinking about covering this COVID, there's so many different health science, so that's a big thing that we have to do. If you teach kids from the time they're taking the soil, like people don't take the soil anymore.
Yeah, fifth graders don't have disease fatigue. You're right. I totally agree with you.
But you mentioned the word that we're still working on, and that's trust. I mean, we all experienced a situation where there was conflicting information, uncertainty, risk associated with an unknown, and everybody was freestyling on how things should work out. And so, to some degree, thankfully, vaccines were developed, which are the reason why we're all sitting in this room right now, and we were able to actually go out. The value of that, I think still needs to be reinstituted because we're dealing with a very different problem now, which is people not getting vaccinated still on a regular basis. Children are behind their schedules because they missed that time period during COVID. And unfortunately, we're seeing an increase in other pediatric diseases as well in the meantime because of this lost time. So just back to your point, maybe also prevention as another way of instituting that knowledge and making that message really strong is important because there are easy ways that we have developed after all this science and learning that we can try to institute a little bit stronger in our communities as well. Any other questions? Go ahead.
So you guys talked about how microbial problem is international and how various countries all have their own incentive programs to try and generate research. I was wondering, given the fact that pharmaceutical and biological needs are becoming increasingly global and have to worry about markets all across the world with their own healthcare systems and incentive programs, if that has impacted any individual companies' abilities to cause these companies to affect their decision to actually start the research, given that they don't have to just consider that.
Wanna take this one?
That's a really great question. I think one thing that I will underscore is that the move towards finding different incentive models to try and tackle this problem is relatively new. I think we're starting to see these global discussions about what may be able to work in various country contexts to not increase the rate of resistance, but to also ensure that innovators are able to continue innovating and to incentivize that research and development appropriately. I think Jomana referenced the pilot program in the UK that was recently made permanent, which is a really exciting development. Canada is also exploring an incentive model that is a pull incentive, so a post-market incentive, similar to ones that are under discussion in other areas of the world. In the United States, the PASTEUR Act is a pull incentive that is under discussion in Congress that would again provide that de-linked incentive that is not tied to volume, but rather tied to the public health value of a product once it comes to the marketplace. I think you highlighted a lot of the hard decisions that companies have to make, especially if they are working to bring a drug to the market. They have to prioritize where they want to bring that drug to market. Everything takes money, right? And I think we are seeing some more global conversations about regulatory harmonization and how to have approval processes, be it through the FDA and then the EMA in Europe, so that if a drug is approved in one area of the world or in a major market, it can have similar criteria to be approved in others. But then you still have to embark on the commercialization process in various nations. So I think it's on the incentive side of things, the fact that there is a recognition of needing to do something on that post-approval side that inherently impacts the broken marketplace is key. And then figuring out what may work depending on what different healthcare systems look like across the world. What works in the United States may not work in the UK, which may not work in Italy, right? And which may not work in low and middle income countries. But the recognition of that post-approval side and that there is more work to be done is just the beginning. And it's really encouraging to see our global leaders recognizing not only that, but the urgent need for action.
Yeah, keeping in mind other countries have socialized healthcare. We don't. So there are a lot of factors that are taken into consideration about how are we gonna be able to share this, have people access it in low and middle income countries versus the ones that are able to cough up the almighty buck and buy that out. So there are a lot of factors. You mentioned pull. Can you give us a brief description, the difference between a push versus a pull incentive?
Sure, absolutely. So when we're talking about different incentives to help support research, development, and commercialization of products, both in the antimicrobial space and others. We call push incentives that help support or subsidize research and development costs. So for example, there is a fantastic program called CARB-X that is run out of Boston University that is a public-private partnership funded by the US government, also the Bill and Melinda Gates Foundation, Wellcome Trust, and others. And the objective of CARB-X is to provide research grants for early stage research and development of companies that are developing products, early stage science to treat the most threatening infections. So anything that happens pre-approval of a product is considered a push incentive. Other types of push incentives would be streamlining within the regulatory system. So fast track designation, priority review from the FDA of a product. Those are all push incentives that help speed up or de-risk the research and development phase.
Where the government can be involved, because it involves R&D and just bringing things together, not necessarily tapping into the profit of a company just yet. The problem is when you've got the other side when it comes to marketing and making money.
Right. So as Jomana noted, and as I mentioned a few of them, there are a number of push incentives that are in place right now in the United States and then also in other countries. What we do not have right now here in the States is a pull incentive to pull through that technology once it has been approved by the FDA in order to ensure that it's available to patients. So anything post FDA approval is considered a pull incentive, while anything before that is considered a push to push the product to approval.
Can I make a comment about streamlining the regulatory process? So we actually have data on how streamlining the regulatory process can actually intrigue investors to get involved. So there's a term,
money saved, right?
well, there's a term called orphan drugs, which is another term for rare disease or drugs for rare diseases. Roughly 1980, there was a group of people that started a coalition. They're saying, we have diseases, but there's 6 of us or 100 of us or 500 of us. And because there's not enough of us, the pharma companies are not pursuing drugs. And it actually makes sense. It's a little bit, it's different, but similar to antibiotics. There's not enough of a market post-approval for the pharma companies to be pursuing it. So they got congressmen on their side and they passed something called the Orphan Drug Act in 1983. And the Orphan Drug Act actually, it streamlined the regulatory process. It reduced a lot of the hurdles. It reduced the clinical trial sizes. And investors went bananas for the Orphan Drug Act. I mean, there were like 38 or 35 or something like that orphan drugs before that act. Now I think there's over 650 of them, since then. So we've seen what happens when there is an incentive structure in place within the government to get things to market faster, give them the priority review. And so putting one in place is not just fiction. I mean, we have facts to prove that it actually works.
But getting the orphan drug designation is also difficult.
I agree. So, and I'm just spitballing here.
No, I
So,
hear you.
So if you've got a rare disease, antibiotics, in my opinion, are becoming a rare drug. So I'm not a policy guy. I just don't see why we can't sort of copy paste one onto the other.
No, but I know, what I can tell you is that the orphan drug model was explored. It just wasn't sustainable. Another thing that you all may not know is that our nation has what's called a strategic national stockpile. Okay, this is the US's like pharmacy that we hold on to in case of emergencies. When a public health emergency is declared, we tap into it. We did that with masks during COVID-19, with ventilators and others, so that we can hopefully supply, the nation with that. Antibiotics are part of the SNS. The problem is that we don't have new antibiotics as part of the SNS, and that's what we're trying to, hopefully get to a point where, God forbid, anything were to happen, we actually have a stockpile that's able to address whatever the nation needs. There was a question here in the back. Did I miss? Yes.
I guess my question is that in this like medical world that's so impacted, fueled by like ratings, reviews, medical standings, is it actually feasible to decrease the prescription rates of antibiotics? If let's say one doctor won't prescribe you antibiotics, you can still work.
So now it's an interesting comment. The wonderful world of social media and ratings.
Yeah, well, and again, just how healthcare is approached these days. I totally appreciate that. I mean, again, I'm a big believer. Let me just backtrack a little bit. I love my job because I have very meaningful relationships with my patients. That includes my patients with HIV. I actually started infectious diseases as an HIV doctor primarily, and as an HIV activist, and we've come a long way in terms of HIV care. If we sort of restructure the healthcare system to reward those kinds of that time that you can spend, I think that people will love their doctors and be okay with not taking antibiotics. But I think that is just what we need to continue to advocate for.
It's trust too.
It's really
It
trust.
boils
Yeah,
back down to trust.
Yeah, it really does. It boils down to trust. Yeah, and
Oh, go ahead, Mike.
This, on that point, when we were showing my previous film Existence in Winston-Salem, North Carolina, and there was a doctor on the panel who was an infectious disease specialist who'd been part of the Joint Commission looking at stewardship. And they were wondering, how can we, because this was an issue that doctors kept saying, like, oh, everyone demands an antibiotic. So they wanted to examine that empirically. And what they found was actually patients just wanted something to do. What they didn't want was just say, you're fine, just go home.
Right.
And so they worked with Johnson & Johnson and came up with these little care packages that had like electrolytes and chicken soup and like some things and a little info brochure. And then in post study analyses, they found that actually the patients that got the little care package, if they spent the same amount of time with those patients, the approval ratings were higher. So it wasn't that they were demanding an antibiotic per se, but they were demanding something.
They walked away with something.
Yeah.
No, that makes sense. Yes.
Oh, just as a segue to that, I mean, it's a society of instant gratification. So just having something you can hold because, oh, the pill's going to help me. It's, just take it and I'll get better. No matter what pill they're, advocating. So it's having something to hold, it makes a big difference. I also wanted to make one comment in that I did not bring pencil and paper and I'm learning so much. I feel like Brad's speaking to me as a fifth grader, oh, okay, wait a second, no more hand sanitizer. I have all these family members still getting out their hand sanitizer every 2 minutes.
It's not a substitute. I know,
Right.
we keep telling people that.
So, but is there any way you could give us a few very basic links or resources after this as a follow-up to the lecture that we now attended? Or
Yeah, no, I think we're gonna have some, because we have one more sneak peek for you to look at. So, and at the end of that, there are links, but if you, there are some, easy and simple things that you could do. By the way, the nutrition comment was excellent because I think our microbiome has been depleted over the years. Dr. Marty Blazer, who was our previous chair, is like the father of the microbiome. He wrote an excellent book about it, showing the correlation between antibiotic use when you're young extensively and the plethora of diseases that you end up with as you're getting older because you don't have that diversity in your gut. And gut health is something that we're learning more and more about. So something as simple as just eat seasonal. You don't have to have avocados every day. You know, it's okay. You know, you can just change up your diet, eat different things, wash your hands, and just maintain a healthy lifestyle that's balanced. And that's the simple everyday stuff that unfortunately we do underestimate and undervalue because we're this go society that even getting a decent night's sleep is very difficult to also have. There was a lady in the back with the hat. Go ahead.
Regarding a lot of this, what's stopping?
I love that question, and we're still trying to answer it. Because yes,
We do have diagnostics for viral infections, they're just very expensive and they're not scalable at the moment, you know? And this is again where it comes back to trust, right? You know, you don't need a test to make a diagnosis. This is why we spent 8 years training to actually become doctors, right? And at the end of the day, as long as you sort of explain those things, one of the things that one of the take homes, it's not a care package, but I'll say tea with honey. It's as simple as that for a cough, right? And it does, you know, there are data to suggest that tea with honey can actually be a very effective cough suppressant. Those kinds of sort of care packages that come in either a handout or, you know, or just verbal communication. And also, I think the other piece of this is this idea of making sure that they know that they can come back with questions, right? So not just sort of ending it there, but, you know, having that safety netting. We call it safety netting, actually, you know, making sure that and if you get worse, please let me know. If this happens, please let me know. Those kinds of things, I think, can build trust.
Oh, for sure. And also just to add to Dr. Vijayan, diagnostics, unfortunately, there's a cost factor, there's a time factor, and there's an efficacy factor as well. And all those things also fold into the 10 solid minutes that you have that clinicians are able to give you their diagnosis based on clinically seeing you. A diagnostic means you're going to sit there and wait for what, how long, how much longer?
Yeah, 24 hours. I mean, there's point of care diagnostics.
Yeah, it depends on.
Most diagnostics are 24 hours. All with, you know, and every test has their sensitivity issues, their
Right.
specificity issues, you know, nothing is perfect. So it has to be taken in the context of the history and the physical and all of the other things that we are trying to do in those 10 minutes.
Yeah, personally, as Jumana, I think that diagnostics need to definitely be ramped up and are a huge part of this equation. Unfortunately, the technology isn't there, the reimbursement isn't there, and we as a society, you know, we've had our council indicate that we need better diagnostics. It's just kind of pushed to the side, unfortunately. Yes, ma'am.
One quick comment and one quick question.
Mhm.
The quick comment is that in addition to nutrition, real food, is the need for more education for parents, kids, on what is highly processed food
Yes.
and how all those highly processed foods really hurt your body because they block a lot of things that your body can get food, but at the
Right.
same time, it so many chemicals that you really don't need. So if you look at the homemade sourdough bread, in fact, the store, you'll see a lot more ingredients than just pork.
Right.
That's the one thing. And the big question I have is this issue we're talking about today, basically a first world problem in very highly medicalized societies? Do we have real data on, let's say, what's happening with people with in the desert, in the cold areas, and people don't get so many antibiotics. Is there this kind of problem? I mean, I know that MRSA is related to this, but my question is, to what extent is this really a personal problem caused by overuse? And I just want to know whether there's real data on this.
No, that's a great question.
Everyone's handing me the microphone. It is absolutely not just a first world problem. And I was thinking during our discussion of global incentives and global companies that that one of the people who did the most for global advocacy and making people understand that this is a problem of pragmatic solidarity with other people in other parts of the world was Paul Farmer, a medical anthropologist and a founder of Partners in Health, and an enormous advocate for really making people understand that multi-drug resistant tuberculosis in Peru and in Russian jails was a problem of the first world as much as it was a problem of Peru and Russia, exactly because bacteria don't stay in people or in jails or in institutions, but also their constituent genes, as we heard briefly, they travel on mobile genetic elements across the bacterial world. So this really is a global environmental problem. It is not just because we use antibiotics as therapeutics in medicine. Again, if you take the historical perspective, you see that almost immediately after discovering that we could use microbes to grow these really biologically powerful molecules, people were skimming off the production sludge and feeding it to animals and being like, this is great. You know, it really helps with making these animals grow faster. And this is not just animal production. Antibiotics are used in growing fruits and vegetables as well. So it is a result of living in the 21st century after having achieved mass production on a global scale. And so we can't say, well, this government over here, you know, they did a really great job. And so there's not much, you know, patients are very responsible over here in this one country. And so they don't have a problem. When you have an environmental problem and when you have a problem of the microbial world, it's not the same everywhere, but it is nonetheless not something that is divided up by nation states or the kinds of boundaries that we might expect it to respect.
And the real data you're mentioning, the reporting component is also a huge factor, right? So we have our data, the US, the UK, you know, the first world folks, but there is a ton of resistance and LMICs that just isn't reported because of also access, rural areas. It just goes underdiagnosed and undermentioned. Right, did you have anything to add or Dr. Vijay?
I was just going to say, I mean, we talked about sexually transmitted infections. Drug-resistant gonorrhea actually our first identification was in Japan, and then it sort of slowly migrated towards the US. We have India, actually, which does, you know, is a country that does use a lot of antibiotics, and they are now sort of building up their infectious disease workforce, was the first place that we actually identified what we call carbapenem-resistant Enterobacterales. So, you know, that it is an issue of just not diagnosing. I do think that's a huge part of it. The last thing I would say is, you know, there was a study that actually looked at rural women who were prescribed antibiotics for urinary tract infections, and because they didn't have as close contact with their doctors, they were actually given antibiotics for longer periods of time. So there's all these other factors. I would say, if anything, you know, places with poorer access are much more vulnerable to these things for multiple reasons, not just antibiotic use. But you know, it's very much a cross-disciplinary problem.
Well, we're getting close to time, but I want to make sure we get everyone's questions before we start closing out. Any other questions from the audience? Well, we're gonna have a networking break afterwards, so you're more than welcome to come up and ask us. But before we transition things, I still want to give folks an idea about what else can they do? What is the takeaway? What is the, that one thing that they can change in their life or change in somebody else's life to make a difference? And then on a policy level, we answered that for you. So Dr. Landecker, anything else that you'd like to add?
Well, I like all the dietary things. Eat more fiber.
There you go.
I'll go back to what I said earlier, start teaching them younger and respect the fact that it's gonna stay with them, and then they'll probably end up teaching us more about it later.
I was actually going to highlight Dr. Landecker's comment about not blaming people for getting sick. I thought that was actually really poignant because I think we have, especially in this COVID world, we've started to blame a lot of people. So not blaming people, being okay with maybe getting sick, but also doing your part to prevent things, including getting vaccinated and encouraging, your colleagues and being those trusted messengers for your communities.
And then I think for me, I'll continue to highlight policy. I think Dr. Landecker mentioned the lens of being a professor here at UCLA and coming from Washington, D.C., the impact that policy can truly have on all elements of our healthcare system. I mentioned one policy today that is interesting and that could make some big change for the antimicrobial sector. I'd encourage folks to read about antimicrobial policy, Pasteur specifically. There will be some more information around for you all to check out. Take a look and continue to learn about those policy solutions as well.
And I'll say, coming from the federal government, join advisory committees if you know of a federal advisory committee on a particular topic. Ours in specific is on AMR. Everybody from the general public is welcome to join. We have a public comment session that you're able to say your piece, share your story, and give any sort of feedback to our council members in the process of their deliberation as they're coming up with recommendations for the reports. And just be involved. Just be involved as much as you can. There's a ton out there that you could try to find out about within your communities or at a higher policy level, or even in grassroots. You could speak at your little sister and little brother's school, or try to educate, whatever it is. There's a lot that you can do. You just have to have the initiative to do it. And with that, are we gonna do the Representative Levin video? Do we have that, AV folks in the back?
Thank you, UCLA, for.
Oh yeah, do it.
So just to take a moment, first of all, everybody here who braved the rain, all of us who flew in from out of town are a little bit annoyed, actually, at LA for actually raining the couple days that we were here. But thank you to everybody for being here. And obviously the people that joined online, I know we're in different time zones, but I know this will be watched again later. So for taking the time to listen. But in particular, Peter Evans, Hillary, Mitch, it's been Dean Valenzuela. It's been amazing working with everybody here. UCLA is such a great partner. Getting the conversation even started like this, maybe we can make this a traveling show. It's just been a pleasure to work with you guys. And again, thank you to everybody for being here. So just wanted to say that.
Thank you for bringing us together. All right, here's the man.
Hi, I'm Congressman Mike Levin, and I'm proud to represent California's 49th Congressional District. I want to thank UCLA for hosting this important event on antimicrobial resistance and for inviting me here to speak. Wish I could be there with you in person today, but know that I am committed to passing legislation that addresses the global rise in antimicrobial resistance, or AMR, which is a rapidly escalating global health crisis. Every year, 2.8 million Americans are infected by drug-resistant pathogens that require treatment with advanced antimicrobials. I'm grateful for the experts on this panel who help treat these patients and are here to discuss their experiences with AMR. Their work and experiences are key to educating the world on the impact of AMR, which has made viruses deadlier and future pandemics more likely. COVID-19 served as a reminder of how important infectious disease research is as we prepare to prevent the next pandemic. A study conducted in 2021 found that nearly half of COVID patients with a secondary bacterial infection died, and 3 in 4 patients who had more than one bacterial infection died as a result. Unfortunately, the pipeline of novel antimicrobials is dwindling, and fewer companies have the capability to invest in research and development to discover new medicines. That's one of the reasons I introduced the Bipartisan Superbugs Act to help prepare for future pandemics by directing the Department of Health and Human Services in consultation with the State Department to coordinate a strategy and partner with foreign countries and multilateral organizations on the development of new antimicrobial drugs. I'm also a co-lead of the Pasteur Act. This bipartisan, bicameral legislation would empower the Department of Health and Human Services to support the antimicrobial drug industry through a subscription-style contract model. This model would give drug manufacturers an upfront payment in exchange for access to their antimicrobials, which will revitalize an industry that has seen bankruptcies and market failures in recent years. We have a lot to do and a long way to go, but with legislative efforts like these, I'm confident Congress will continue to find new ways to address AMR and fund new research and technologies. Look forward to working with you on these important issues and bills and combating the growing risk of AMR. So again, thank you to UCLA for hosting this panel. Thank you to the specialists who are working each and every day to educate the world about antimicrobials and the resistance to them. Hope you have a productive conference, everyone. Take care.